Welcome everyone. My name is Dr. Fahim Shakur, and one of the co-hosts for tonight's webinar, which is reaching globally on our MEDtalkx channel on long COVID. Hopefully, the instructions are very simple. We hope to have a whirlwind whistle-stop tour of this really interesting and topical topic. We'll go through the definitions, then we'll have some lived experience about long COVID, and also we'll have a respiratory physician at the end talking through some of the complications and other things from COVID. Please do ask questions during the actual talk and leave them for the end, and we hope to go through it. I'm also conscious that, as I said before, that there will be some personal insights that are expressed, and so please be mindful of this. It's a very sensitive issue. Some of you may have had COVID or know people who've had COVID and suffered with it, or even suffering still with it. So it's a bit of a trigger alert, really, just to make sure that you understand if it builds any emotions in you. And also, if you can just be mindful that one of our guests will be speaking about their own experience, and really that's a privilege to have that. And so if we can just be empathic to that. The speakers take personal responsibility for their own slides, and where appropriate, they do reference their viewpoints as well, but they are their personal viewpoints. It is obviously 2nd of February, 2021, for those of you who watch this on our channel at a later date, and the information we provide is up to date at time of transition. I hope it's educational, hope it's informative, and I hope it's insightful, and I hope you forgive us for any mistakes we may make. Over to you, Mehran, to introduce our guests and furnish a bit more information about MEDtalkx to our audience.
Yeah, thank you, Fahim, and welcome everyone for joining this webinar about long COVID. Before I make the necessary steps in introducing ourselves, and as well as the purpose of the webinar, I just want to give our heartfelt condolences and wishes to Captain Sir Tom Moore, who passed away earlier today. So this is gentleman who's 100 years of age. He captured the nation's hearts by walking 100 laps in his garden and did a great deal for NHS charities. So rest in peace and our condolences, and I'm sure you'll join me in passing our condolences to his family. So before we start, a little bit about MEDtalkx. So Fahim is a general practitioner in the Northwest, and I'm an old age consultant psychiatrist, again in the Northwest region, and we embarked on this journey of trying to plug a gap because we thought there was lots of information that needed to be shared, and it's free from the point of access. So please do check out our YouTube channel. It's MEDtalkx, and I will put the links out. So just to be aware of, there are a couple of future events on February the 17th between 7:30 and 8:30. We are discussing the Mental Health Act and the recent reforms in the white paper, and March the 17th we'll be talking about medical leadership, where we will be joined by some esteemed guests, including Professor Bumrah and Dr. Jain, plus others. So clearly it's an action-packed schedule, but without further ado, let's start off with our conversation on long COVID. So our first guest is Dr. Goyal. Dr. Goyal, if you're able to start sharing your slides, that'd be great. And she is general practitioner in the Birmingham and Solihull CCG. During the pandemic, she's been involved in multiple projects to allay fears about COVID-19, build trust, and encourage public health practice. She's also on the board of the RCGP Midland faculty, as well as being on the Faculty Fellowship Committee and a formal regional lead for a National GP Leadership Development Programme. She is her practice lead for undergraduate education and also has been recently busy with medical school admissions. So clearly, she comes from great wealth of experience, but certainly her interaction with COVID and its subsequent effects in primary care would be really valuable. So over to you, Dr. Goyal.
Okay, thank you. Thank you for inviting me to speak today. I'm here to give you a GP view on long COVID. So I'd like to start by identifying the problem. So at the start of the pandemic, the effects from coronavirus were essentially a tale of two outcomes. So either it was this mild self-limiting illness that people largely recovered from and went back to their normal lives, or it made people seriously unwell, and those individuals unfortunately overwhelmed our hospitals, and many thousands of people sadly lost their lives. And this tale of two outcomes was reinforced really by the government briefings, which tended to concentrate on positive COVID swabs, but also mortality figures. And this narrative may have given a false sense of security for young people or those without comorbidities, because it made them feel that coronavirus was nothing to worry about and that they could essentially ride it out. But then a pattern started to emerge of people who were essentially suffering for longer than expected. And these individuals came from all backgrounds and all ages, including children. And because they weren't unwell enough necessarily to be hospitalised, they were left to manage on their own. And there was a largely patient-led movement to kind of get this recognised and to find out what was going on. I first learned of the term long COVID when it was used as a hashtag on Twitter by Dr Aaliya Goyal. And all of these patient voices, they led to a growing call for understanding and more research to try to help these individuals. And the NICE guidelines were published in December of 2020, and they were guidelines on managing the long-term effects of COVID. And they were produced jointly with the SIGN and the Royal College of GPs. And this essentially gave 3 definitions for the symptoms of long COVID. So there was an acute COVID-19, which was signs and symptoms for up to 4 weeks. There was ongoing symptomatic COVID for 4 to 12 weeks. And then there was a post-COVID syndrome, where the symptoms went on for longer than 12 weeks and weren't explained by an alternative diagnosis. And there was also a note in the guidelines about long COVID, which essentially included the latter 2 categories. So ongoing symptomatic COVID-19 for more than 4 weeks. And it's really important to understand that in order to get this definition, you don't need to have a positive antigen or a positive antibody test. And the reason for that is, as we know, at the start of the pandemic, many people didn't access a test. And that could have been because it wasn't available. It could have been because their symptoms didn't meet the case definition. But also, it could have also been because they didn't want to get tested, because many people couldn't afford to self-isolate. And in terms of the prevalence, I've seen lots of different figures. The one that's most commonly used is 10%. And these figures were informed by the UK COVID symptom study, which is essentially an app which encourages people to input their symptoms daily. And it's really important to think about that for a second. So as of last week, so the 29th of January, as far as I'm aware, there were 3.7 million positive swabs. So that means that we could have up to 370,000 people living with long COVID. And the implications of that are huge. I really wanted to find the perfect infographic to display the symptoms, but I really struggled to find one. And the reason for that is because, according to the post-COVID syndrome group anyway, there are over 170 symptoms and counting. So if you look at this on the right-hand side, it's the most common symptoms and the sources at the bottom. So as we can see, long COVID, it's a multi-systemic disorder. It affects people from head to toe. And it's thought that the more symptoms someone gets in the first week can be used as an indicator of risk of development into long COVID later on. And as well as all these individual symptoms on each of the systems, as noted, there are also things that are a little bit more difficult to quantify. So for example, things like brain fog, lung burn. It's a relapsing and remitting condition. So patients may feel that they're suddenly getting better and then something else will happen. And so they're constantly left with disappointment. And according to the SAGE guidance last week, the average length of symptoms is 140 days old. But as I've explained, the numbers are changing all the time. I did see a good infographic only yesterday, and this was on the long COVID SOS a Twitter page, and I appreciate it looks very busy, but that's simply because there are just so many symptoms. And in terms of the damage that COVID does, it damages in lots of different ways. So it can weaken or kill the cell that it invades. It can damage through a really intense inflammatory response, or it can damage through clot formation. And this is why it's vitally important for GPs to understand. And we can use, so I'll talk about the role of the GP. So we can use our GP privilege. And by that, what I mean is the privilege of knowing our patients well, having a long-term relationship with them, as well as listening to our patients. We can document not only the symptoms, but also how they change. And we can also encourage the use of symptom tracker apps. It's really important for our patients, for them to be aware, to let us know if they're still not right by 4 weeks, because they don't need to suffer alone. In my community that I work within a very, very diverse population, and I'm acutely aware that symptoms, not just of long COVID, but of many things, can look, feel, and present differently in different communities. And some communities may not have the language skills to articulate how they're feeling. So in terms of the role of the GP, so we can investigate after 4 weeks, and that's essentially blood tests and tests of cardiac and lung function. If patients remain unwell, we can do a chest X-ray by 12 weeks, and we can also manage their comorbidities. And these will inform the outcomes. So this was taken from the Royal College of GPs. It's their top tips, and it was published just before the NICE guidelines. And as you can see, in terms of the outcomes, it could be that patients can self-manage. It could be that they have a community management set up. But importantly, we now have long COVID clinics as well, which I will touch upon later. As I've mentioned, COVID can cause damage by clot formation, and it's vitally important that we are continuing to monitor these individuals, because they can become unwell at any time. Even if they haven't been admitted to hospital in the beginning of the illness, clots can happen, and it may cause them to become acutely unwell. And a lot of my patients, they're in underpaid jobs. They don't really have the luxury of paid time off work. And so because long COVID can last for weeks and months, there's an intense pressure to return to work. So I was asked to say a few words on sick notes. So I'm just going to highlight the existence of a document. So this document exists. It's from the Faculty of Occupational Medicine, and I'm sure it's on their website, but it's also on the Royal College of GPs website. And I actually got it from the NHS England Primary Care Bulletin from the 19th of January. So needless to say that we are being informed of changes all the time. This is called a living document, so it's due for review at the end of March, and it draws upon general principles. So work can be good for health. You don't need to be 100% fit for work in order to work. And for some patients, going back to work can be a form of rehab for them. If we write on the form long COVID, that could also help in terms of allowing special adjustments to be made. And I think it's really important to ensure that we put some detail in there. So I do when I write sick notes. So it's the aspects of the job which may be affected by functional impairment. Can the patient identify solutions? How can we help them? We should always encourage them to have a conversation with their employer as well. So as GPs, it's really important to validate experiences, acknowledge frustration, and treat with compassion, because long COVID, it's debilitating and it's very, very frightening. I'm just going to touch upon the NHS England and Improvement 5-point plan for long COVID support. So this came out in October, it's the 7th of October. And as well as the NICE guidelines that I've mentioned already, there's an online rehabilitation platform along with the along with COVID clinics and funded research. And there's also a task force to ensure that these things are done. And importantly, that task force includes patient representatives. The online rehab platform, if you go onto it, it looks like this. It's actually quite good. So there are sections on managing the effects on the body and the mind and on other conditions. There's also a referral for doctors to refer people to an online rehab service. And I would strongly urge my colleagues to just have a play around with this website and see the information that's on there. This is phase 1 of your COVID recovery. There's a second phase planned, and that will be an app with a more tailored approach to rehab. There'll also be peer support and an Ask the Expert facility on there. I've touched upon long COVID clinics. So this diagram was taken from the independent SAGE briefing of last week. In my area, we have our own flowchart, and I'm fairly certain that there are different flowcharts in every area. But I use this just to show a general principle that after the GP's done a holistic assessment and investigate, we can refer for a thorough physical, psychological and cognitive assessment. And this will inform a personalised care plan with the follow-on services as necessary for that individual patient. I'd just like to highlight a few more resources. So locally, we have a pulse oximetry service. I have access to a phone app. So if you look on the right, that's a screenshot that I took from my phone. It's for healthcare professionals. So the second thing on the list is a COVID advice line. So I can use that and I will be connected to a specialist immediately. and I will get specialist advice. So there are things exist that patients may not be aware of. And as GPs, we're also encouraged to use coding into the patient notes, and this will inform a future register, hopefully. Dr Nasreen Alwan has been an advocate, quite rightly, for some method of counting long COVID, and we absolutely want to help in doing that by using codes in patient notes. There's an excellent infographic from Professor Trish Greenhalgh in the BMJ. This was produced before the NICE guidelines, so at the top it mentions 3 weeks rather than 4, but it gives the general principles which I've already touched upon, and also there's a section at the bottom for both medical management and self-management to empower the patient with daily oximetry, etc. There's also resources on the RCGP website, and they also held a webinar in December. So finally, I'd just like to share some final thoughts. So it's important to appreciate and share the uncertainty that we all hold. Dealing with a new illness is hard. There's no single test who will get long COVID, and there are many ways of having it. We've only just reached the 1-year anniversary of coronavirus 19 being called a pandemic by the World Health Organization, and research is evolving all the time with new guidance and new information. And honestly, the information overload, it can be overwhelming. We also need to remember the key strategies of primary, secondary and tertiary prevention, and which I'm not able to go into today, but the most important thing that I've learned from long COVID is the importance of a patient as an expert. We are learning from each other at the same time, and I've learned a lot from Dr Seema Charters, and I hope that I can continue to support my patients on their journey. Thank you.
Thank you, Dr. Goyal. That was great. I am going to ask Dr. Charters to start sharing her screen. So a little bit about Dr. Seema Charters. So she is a consultant anaesthetist in Warrington and Halton NHS Foundation Trust. She is the Airway lead as well as Trust Sedation lead. And what's evident is that she is passionate about teaching and promotes safe practice and sedation throughout her trust. She has written in the Royal College of Anaesthetists bulletin and has been invited to speak on the subject of a national conference. But it's clearly her experience about COVID and living through it that really is something of keen interest, and certainly we can learn from. So she's been involved in national meetings to talk about it and to raise awareness about long COVID. So over to you, Dr. Seema Charters.
Hi, is this seen well? Yep, okay. So thanks to Long COVID Support Group for suggesting my name for this webinar, and thanks for him for this invitation. I have given talks on my COVID experience before, but the discussion that we had with each other in leading up to this webinar have been a rewarding experience for me, and I've learned a lot. So I believe my COVID story started on 20th of May, and this is a story of a doctor and anesthetist. And in this story, I did get the infection severe, which involved hospitalization with ICU stay, but I wasn't sedated or ventilated. So I experienced the dread of seeing this illness from the other side. So therefore, this is a personal account of a patient while being a doctor and anesthetist. So on this particular day, I had anesthetized the patient undergoing an elective laparoscopic surgery. And on the day testing COVID was negative, but next day his previous swab result came positive. And subsequently, the FFP3 masks that I had worn while anesthetizing this patient were found to be leaky on electronic testing. So on 10th of June, when I went to work, I felt sleepy really all day. And when I got home, I developed high temperature, and I just felt really ill. Luckily, this was June, so I got tested very quickly next day, and I carried on having unremitting temperature in that week with severe exhaustion, loss of appetite, and change in taste. But I had no cough. On third day, following this testing, I had the positive result. And I remember this day very clearly because the UK had reached a grim milestone of 40,000 deaths on this day from COVID-19. I certainly didn't want to add to this statistics. And the thing to note here is that even though you're a medic and anesthetist, no one has really prepared you for this illness and the dread you feel when you get the result for this virus. Once you get the result, you start worrying about that you have no risk factors, but why your temperature is not going away. And the usual course of the disease is 1 to 2 weeks of temperature. So why am I still so ill? You feel really isolated in that worry, and it's a personal hell one lives through. And negative thoughts really played very heavily on my mind. How would I say goodbye to my loved ones? And they really cause annoyance to my hubby. But by next week, my temperature swings continue. I still didn't have any cough or shortness of breath, and that made me feel that things are not too bad. And the NHS advice at the time was to stay at home and not ring 111 unless you weren't coping well. But on 11th of June, my husband noticed really rapid breathing on my part, and we decided to ring 111. And then the things moved on very swiftly from there. We were asked to go to emergency department to my local hospital, which is Wirral University Teaching Hospital. I was asked to wait in the ED reception area, and my husband had to wait in the car. But while I was waiting there, I suddenly couldn't draw a single breath of air. I thought as if someone is sitting on my chest, and it was really a terrifying feeling. I must not have waited more than 10 minutes, but that was the longest wait of my life. And the moment the ED doctor saw me, I just told him, give me oxygen. And the events that followed were very quick. I was put on monitors, oxygen. I was taken to respiratory ward. My oxygen requirement started to increase that evening. So then I was taken to ICU for CPAP, and I was admitted to ICU. It was a surreal experience to be on ICU as a patient where I had worked as an anesthetist, as a trainee anesthetist number of years back. Coping with CPAP was no small task. Even though I'm an anesthetist, it really feels claustrophobic till you get used to it. And I was just praying that let this be the thing that will help my oxygenation. I had all the lines and things put in that night, and ICU nurses in Arrow Park were really very understanding. They supported me with encouraging words. Luckily, I responded to CPAP, and next day they put me on high frequency nasal oxygen. And this warm humidified oxygen was really extremely comfortable. Next day, I was happy to see the ICU consultant, which was a familiar face from my training days. I was put on Remdesivir. By evening, I came down on 4-liter nasal oxygen, and I was moved to HDU. That night, I was really exhausted and remember feeling quite depressed about my illness. But again, the nurses were just tremendously friendly, and I really didn't feel like leaving HDU when they told me next day that I'm being taken to now respiratory COVID ward. On the respiratory ward, again, my oxygenation dipped overnight, and I was told, respiratory consultant told me that I have to have a CT pulmonary angiogram to rule out pulmonary emboli. My heart really sank at this news. I really didn't need another bad news. And CTPA was an unforgettable experience because of the dye that it creates in your body. And I was relieved to find no pulmonary emboli, but my CT had a classic appearance of COVID-19 infection. And then from then on, I stayed on the respiratory ward till about 20 days. On day 21, I got discharged. My appetite came back well after I was put on dexamethasone once the recovery trial got published. I was in a single room, so it was a quiet period, but I had lost a lot of weight. I had become quite frail, and I was getting short of breath with really basic daily activities. I really received a gentle care from the respiratory ward nurses, and I was really this was quite a humbling experience for me. And I got discharged once the oxygen requirement was reduced, and I got discharged without any oxygen to home. When I came home, I just thought how incredibly lucky I am. And in the weeks that followed, I still was getting quite breathless going up and down the stairs. I put it down to COVID lung injury and muscle wasting, but these symptoms were persisting after 4 weeks also. I just couldn't understand this sudden weary feeling I used to get, and this burning in my throat, my tingling around my lips and tongue. I couldn't concentrate on doing any work at all on my laptop. I used to feel lightheaded while bending over, and I just couldn't understand what's going on here. So my husband suggested, why don't I talk to one of his intensive care nurse colleagues who has been through COVID? And finally, she became my COVID buddy. We exchanged notes about the fatigue I was feeling. And she suggested me reading blogs of Professor Paul Garner's. And when I read his blogs, I realized that how he has been through this frightening experience that he described when he contracted COVID in March. And he had a mild illness which didn't need hospitalization, but then he carried on having symptoms. And this is the first time I came to know that he's not calling it a post-viral, but he's calling it a long viral illness. And then I came across the term long haulers, or as we now call it as long COVID. And it started to become clear to me that I may be falling in this category. So Professor Garner had mentioned support groups. So I turned to the support groups, and this is these are the support groups that are there in UK and USA. This long COVID support group is UK based, and long COVID SOS is another support group, which is, I'll talk about long COVID SOS group in a minute. And Body Politic is a USA based support group. And this is the support group that I joined initially. And I really learned a lot because of joining these support groups. Because, for example, this Body Politic has got lots of channels. It's a Slack platform. And there are channels, as you can see, which are symptom-based. There are channels based on where you're based, which country you come from. And I have just highlighted here sleep and fatigue. So when I started reading all these patient stories, I just felt kind of validated, and I learned a lot. And this is really the first illness that has been collectively made by patients, finding one another through Twitter and social media. This article by Eliza Perego really beautifully describes the journey made by these long haulers all over the world to get to the understanding that we have today. And the knowledge has just traveled from patients to media to formal health and policy channels. So these are some of the support groups that are out there, and you should, if you're in this category and you want some help, these are very helpful. And this long COVID SOS campaign was formed by the long COVID SOS, and this is the video they put out. And I would like you to have a look at this video.
We're all members of a club no one wanted to join. Different backgrounds, ages, experiences. Thousands and thousands of us have been struggling for weeks and months with ongoing symptoms of COVID-19. These are some common symptoms, but there are many more. Some of us have been ill throughout, with others having relapses. We're still very ill. We're feeling pressure to return to work, to care for families, and get back to normal, when we still feel anything but. No one seems to be able to answer our questions or give reassurance. Will we ever get better? Will there be long-term repercussions for our physical and mental health? Is this post-viral fatigue, or are we still infectious? Will I be able to do the things that make me happy again? Can we hug our loved ones, or will we make them sick? Is this damage irreversible? Am I going to die? We just don't know, so we're sending out an SOS. Each of us has our own journey, but lots of us are feeling abandoned, dismissed, brushed off, ignored, and given conflicting advice. It can be hard for those around us to understand how ill we are. It's confusing and scary. Our numbers are growing and we need to be taken seriously. We need rehab, research, and recognition. We need to be believed, helped, treated with compassion, and supported by those around us. Please hear our SOS.
So this message in the bottle campaign was launched by a long COVID SOS group, and it really got successful. It received a lot of attention from media. Then WHO also invited these patient support groups in August, and WHO heard their demands about research, rehab, and recognition. And finally, UK government also. And I hope you felt from this video the sense of abandonment these long haulers are feeling. And I feel the same emotions yesterday when I met one of my surgical colleagues who's been going through long COVID symptoms like myself. And he said the same thing, that Seema, people just don't understand what it is like for us. And this is the reality for us. And it's just difficult to explain what symptoms, because these are the list of my symptoms. Now, they didn't come all in one go. They have been varied from week to week and month on month basis. Some have still stayed on and some have still persisted. I still have got a lot of fatigue. I still get burning in throat and throbbing tongue around, like pins and needles around my mouth when I'm extremely tired. So this neuroscientist, David Petrino from Mount Sinai, described it very well with his experience of treating the patients on long COVID. He says that it's like every day you reach your hand into a bucket of symptoms, throw some on the table and say, this is you for today. So the patients, especially those who have got cardiovascular symptoms or autonomic nervous system symptoms, it is really, really very scary, because they don't know tomorrow or next week what symptoms they are going to feel. And this is what adds to the anxiety these patients are feeling. And I was quite touched by all these accounts of people that I read on Body Politic. And when I decided to kind of join work, the last symptom I had was costochondritis. And I really didn't know why am I getting this weird chest pain and quite severe chest pain. And I really managed to get very good advice for costochondritis pain from someone suffering from it for a number of weeks following COVID from Body Politic. So when I got home from the hospital, initially I had to go to GP for my blood test. And this first consultation was reasonable in terms of finding out what I had been through. And some weeks down the line, when I couldn't understand how to deal with this throat burn, I contacted GP and I was started on omeprazole. I kind of was looking for understanding of long COVID, but I didn't get that kind of discussion from my GP, and I was still not sure, is this long COVID and is this what I have? Then the third consultation I had with my GP was about 4.5 months down the line, and that was for this chest wall pain. And this was a very reassuring consultation. He confirmed it was costochondritis. We talked a lot about long COVID. He ordered a full battery of the test, and I felt really listened to. I felt his empathy. And this is something, it's really important to patients. Even though I'm a doctor, I wanted to be listened to. And the sick notes, I used to get extended every 2 weeks, and but there was no kind of consultation with my GP once a month about my sick note, and my occupational health department also hadn't contacted me every week or every month till I decided to join work. So this is something important to get it right. The critical care team from Arrow Park did a routine follow-up 4 to 5 weeks after coming home, and they expressed concern about the level of breathlessness and fatigue I was feeling. And it was actually them who put me in touch with pulmonary rehab team, and this team started to visit me every week. And if it wasn't for them, then my recovery would have taken a number of months on end, I feel. They used to visit me every week. They gave me an exercise sheet every week to fill out, and they made this exercises intense very gradually. And even then, sometimes I used to get them wrong, and it will send me into a post-exertional kind of malaise. So this was a good example of personalized care plan, because I had to worry about my knee injury as well. And they actually got me ready, thinking about return to work and how to plan for it. And then the NHS COVID recovery website was launched. And advice given on this website was also discussed by this rehab team, and that helped my recovery. Then the respiratory consultant was touching base with me, and I had a number of tests done following my illness. First, chest X-ray, which showed some fibrotic changes. So I had a CT, I had pulmonary function test as well, which were normal. And because I had some fatigue and some breathlessness still left, I had an echo as well, but echo was also normal. But technician did comment on stiff lungs not moving out of the way because of and difficulty in getting good echo images. So this was my experience of primary and secondary care. I was asked to talk a little bit about fatigue management, and I can tell you fatigue management in long COVID is hard work and a full-time project. And even though I thought I'm getting it right, yesterday I had a crash kind of. I had gone to my base hospital, which is 1 hour drive from my home, and I had to walk a lot there, and I was teaching there airway management, and just talking all morning really tired me out. And when I came home, I just couldn't speak very well. My tongue was hurting, my throat was hurting. I had to sleep, even sleep wasn't refreshing. So fatigue management is just not easy. I have put down a reference here from longcovid.org resources website, and this has got a series of videos on fatigue management. I have seen these videos, they do help. They do talk about planning and pacing yourself, try and break down the task into short chunks of activities, take some rest in between. So when I was at home, I used to have, for example, cooking the dinner in the evening. I used to do a part of preparation in the morning, then do partly in the afternoon, and then at night. I had to do computer work also in a short burst and not for a long time. And I had to kind of make sure that I'm not doing screen time or doing WhatsApp, Facebook, not Facebook, but WhatsApp, Twitter, and all these screen times. Also, I had to be careful that I'm not doing too much at any time. My eyes still burn with visual tasks and screen work. So fatigue, it's kind of, you have to stay in your exercise envelope. You have to understand your baseline, and you have to start moving, but you have to start doing it slowly. Try initially going for short walks, then increase your activity in terms of the number of steps or number of days you're going to do this walks in a week. Managing uncertainty in this COVID illness is a big issue, because we still don't know much, or we still don't know enough about this virus. And this source of uncertainty varies as the time passes. Because initially, I just couldn't understand what is triggering my relapses of fatigue, and I had to work out how to pace myself or how to do the activities in short bursts. Then initially, I was really petrified of getting reinfection, because even though initially it was thought as imaginary, because not many cases of reinfection were reported, but now it is a reality. We know that reinfection, 2 of my colleagues have got reinfected. So it does happen. And that scare hasn't gone away, because I have had a first vaccine from my hospital, but my second vaccine has been delayed. So now I'm worried about how am I going to get protected from this variant, and without a vaccine, would I get a reinfection? So this uncertainty still has remained with me. Then deciding return to work was a very difficult thing, and I really couldn't figure out how to slowly come back to work. But my department has been very much supportive, and I have managed to come back to work, but I am not at full-time work yet. I do worry about long-term neurocognitive and cardiovascular effect. I'm awaiting another chest CT just to rule out any lingering changes of COVID on my lungs, but that is another something I have to worry about. And I'm not able to take on any of my extra ISP activities, such as the Airway lead and sedation courses that I do. I have started saying no to many of the things I used to do. So it does take a toll on your aspiration, career, and your ambitions on work front. And I do fear getting labeled as someone who's taking advantage of the disease, or someone who might be perceived as a shirker. I hope not, but sometimes you do feel that what are my colleagues thinking about this? Interaction with friends and colleagues also sometimes do become difficult, because they really don't understand what you're going through. And when I joined on the first day itself, I realized that people are not understanding when I say that I'm not able to speak, my tongue is throbbing. One of them thought I was having acute COVID illness. And that is the time I decided I've got to educate my colleagues, and I've got to educate my trust. So I did a presentation in the grand round, and that really went down very well. So it is our job as a long COVID sufferer to educate others as well. So this is my final slide, and I was asked to give top tips. So this guy, Gez Medinger, he's a filmmaker. He was training for London Marathon, but he contracted COVID in March, and he's been making films. He's made up, I think, 14 films so far. And one of my friends from Body Long COVID SOS group actually sent this video to me, and I have really started to like the way he has analyzed the whole literature, whole scientific evidence. And if you want to tell somebody about what is long COVID, then this 90-second video is a brilliant way to just tell somebody in a nutshell what is long COVID. So he has given some top tips in this video, and some of these are his ideas. But what helped me was having a COVID buddy and have somebody to talk to and kind of exchange your experiences. Please don't suffer in silence. Go and contact your GP. Get yourself referred to long COVID clinic if your symptoms are still severe. Surround yourself with positive people who will energize you. My family and my husband have always kept repeating to me that you're much better than you were before. And that really helps. That family support does help. Accept that relapses and crashes are common, but reassess your baseline. Just don't push yourself all the time because you'll make it worse. You have to keep moving, but you have to keep it in your exercise envelope. There is a lot of talk about having a low histamine diet because it's an inflammatory condition, and not having alcohol, it's a low histamine diet, and that does help. Measure your cognitive work your day. And these are the supplements all these long COVID sufferers on the support groups are taking. I've recently started niacin. You consult your GP before you start any of these supplements. And I would suggest a pulse oximeter, as Dr. Goyal suggested, as self-management. So get pulse oximeter as a family present. And as I said, educate your friends and families. Thank you very much.
Fantastic. Thank you, Dr. Charters, for that very personal and vivid account of your journeys. And certainly it's given all of us a food for thought. And, you know, we do hope you continue on your road to recovery so that you can continue to do the things you really enjoy. So thank you for that. Just for the audience, thank you so much for the questions coming in. We will try to get them addressed after Dr. Mehdi's presentation. So please do fire away. Our next and final guest is Dr. Mehdi, who's a consultant chest physician and trust lung cancer lead at the Lancashire Teaching Hospital in the Northwest. So he was appointed as a consultant in respiratory medicine in 2016 and later as a cancer lead for the trust. So clearly he has a keen interest in lung cancer and interventional pulmonology. So he's very much passionate about teaching, but our experience with Dr. Mehdi is that he's contributed to radio as well as webinars focusing on COVID-19 and associated complications to raise awareness and improve healthcare. So over to you, Dr. Mehdi.
Thank you, Mehran. Can you see my slides clearly?
Yes, perfectly.
Okay, thank you. And thanks Fahim and Mehran, first of all, for inviting me to give a short brief presentation on COVID, potentially post-COVID and long COVID. Now, I was honestly touched with Seema's personal experience, and I'm pleased to hear that you had a good respiratory team experience, which is why we are here, because as you probably know, COVID has heavily impacted the respiratory team of all the teams. And it just, I think your experience just reflects the real life experience of a patient that I've seen with my eyes, though personally I've never had COVID, which I'm really pleased, but I've seen what you've explained very nicely. And Aaliya's obviously given a very nice statement about patients being experts. And I think we should totally acknowledge that fact. And I must disclose that I have done post-COVID clinics, and I've had some interaction with my colleagues, and a couple of my colleagues are actually on the channel now who have helped me with some facts that they have seen, especially Kath and Naz, who is on the lines now, and my colleague, Dr. Gadur, who does predominantly a lot of COVID work in terms of follow-ups. But I think it reiterates the fact that, you know, the fantastic work of the multidisciplinary team in dealing with COVID and long COVID, and that's the only way forward, I think. Well, my job is here to present what should we do when we discharge somebody from hospital after a COVID illness. So I've just put up some points there. So what happens when patients with COVID go home? Some patients go home fairly early in the journey of COVID. And those are the patients I've just highlighted there may need a full course of steroids. And that is, again, a clinical decision to prevent any complications of COVID that we think may happen in the near future. Now, we also heard a lot of talk about pulmonary embolism and clots in the near future. And again, there is kind of a two-school thought on whether we should send people on low molecular weight heparin. And we have adapted in our trust a policy where we generally discharge patients on low molecular weight heparin post-discharge. And I put in the brackets as a clinical decision because there are some situations where this may not be appropriate. A lot of follow-up for COVID is based on our British Thoracic Society guidelines, which are very clearly laid out going back in May 2020. And it's a beautiful document for people who are practicing clinically to look through as to how we should be doing it, what is the primary care responsibility, and what is the secondary care responsibility. And I can tell you from my colleagues' experience and my personal experience, we have a telephonic or a virtual follow-up fairly straight away after the discharge. Exactly like Seema said, usually about 4 to 6 weeks after discharge, patients should be telephoned to check on how they are, even if it is a telephone clinic, on consultation. But like again, Aaliya mentioned this, we do have to make sure we do chest x-rays 12 weeks post the illness to ensure the changes have resolved. Why 12 weeks and why not 6 weeks, just like pneumonias? Because we know COVID is a viral illness. We know this is an inflammatory disease, and we know things will get better. And therefore, the 12-week concept came in rather than 6 weeks follow-up that we normally do for a standard pneumonia. And then subsequently, people may need CT scans, lung function tests, echocardiograms, and various other tests if we need to. The guidelines also recommend that we should actually be doing face-to-face appointments for the patients who've had severe COVID, especially people who've had CPAPs or high flow oxygen, or who've had intensive care stay. Certainly these patients need to be seen face-to-face at some point in their follow-up. Now, if I just briefly outline what are the problems that we commonly encounter post-COVID, very beautifully illustrated by my colleagues already. Residual breathlessness is one of the major symptoms that actually makes patients very anxious, but also I think as medical faculty, we need to look for the causes. The common causes generally are parenchymal problems, meaning something that is actually physically made a damage to the lung. And one thing that's very common or heard of is interstitial lung disease. There was a huge concern when the COVID actually set in to say we'll have a huge number of people who will be left with a lot of interstitial lung disease, which is also nothing but in simple terms, scarring of the lungs. But fortunately, I think we still see quite a few, but I don't think we've hit the same percentage as we were expecting. The other bigger problem, which is something that we should be able to avoid, is pulmonary embolism or clots in the lung, and also the after effects on the heart. Now, the way to avoid it is to try and anticoagulate them adequately, because as you know, most patients are breathless, therefore they're going to be limiting their exertion, therefore they're going to be immobile, and therefore that puts them at a risk of having pulmonary embolism. So it is important that we recognize this, and I think it's important pathology to be aware of. After all of these above have been thought through and patients are still breathless, and then we come into the category of breathing pattern disorders, which is clearly a sensation of breathlessness that is completely out of proportion for a patient who's generally fit and well. So I think it's important we recognize that. Now, some of the ways where patients actually present is very obvious. Patients have reduced exercise tolerance, they desaturate when they exert, and they hyperventilate. And this is real life experience. We've seen patients come into the clinic wearing masks, feeling very breathless, and after a few minutes, they settle down. And as soon as they start doing something, they feel breathless again. So it's a recognized entity. It's not surprising because young people who've got affected with COVID are probably more worried of not getting back to normality. And I think that is a very important message that actually got when I discussed with my team yesterday, to say fatigue, insomnia are pretty common in these patients. And I think we've heard a real life story, and actually that all correlates. And I'll disclose it. I've not discussed this presentation with Seema, and Seema has presented her experience, and you can see the reflection on the slides in my slide set. So this is reality. What do we do? Again, I didn't discuss these slides with Aaliya. Holistic assessment and MDT approach is the way forward. I think physiotherapy, which is exactly what Seema said, pulmonary rehab, which clearly illustrates that we know you need to pace and you need to build up on your strength. And that is, I think, once you've ruled out all the structural and embolism and the other problems, that's when you need to start building up on your exercise tolerance. Certainly, there are some situations where there will be a strong need for investigations in secondary care, which is where I think we strongly recommend you to refer to the COVID clinics. I know there was a question asked. As far as I know, most of the COVID clinics should be well supported with psychologists, with physiotherapists, with occupational therapists. So it should be a multidisciplinary team approach. But let me turn the tables around a little bit. I think we need to look at the positive side. And I'm just going to give you a little bit of a real life story of a patient that I've just seen today in the afternoon. This is a classical X-ray of extensive changes on the chest X-ray. Again, on this X-ray, you can see a lot of changes. This is a fit and well man, very well, ready to go home. What does he do? Just the night before he's supposed to go home, he collapses his lung. And this is a classical pneumothorax, which is not uncommon with COVID. And unfortunately, because of the fragility of the lung, this is becoming more and more common these days. So this man actually collapses his lung. He doesn't stop there. Unfortunately, he collapses the other side of the lung as well. A bilateral pneumothorax getting into this stage where you can see there's extensive subcutaneous emphysema. This is dire states. You can see there's a big chest drain coming in there. Unfortunately, this man, from being ready to go home, is on the bed for 3 weeks with 2 bottles on each side and completely deconditioned. And the first time when he sat on the chair, he couldn't even sit properly because his muscles have just wasted. Fortunately, as I said, there's a positive side of COVID. This is X-ray from today. This is completely normal in the sense he's got some residual changes, but actually in himself, he feels remarkably well. He still remembers everything that went on. He really appreciates the care that he got, but this is the positive side of how we can deal with. This is 3 or 4 months down the line post-COVID. So in conclusion, I think majority of the patients do well. The recovery is full, but what is very important, and I think this has been highlighted again and again, and very clear that it is important to recognize that long COVID does exist. And I think recognizing that it exists is important. And I think there's need for ongoing follow-up for these patients in primary and secondary care. And the work will only get bigger and bigger with long COVID. But I think it's important to recognize that it is a condition that needs to be dealt with. So without any further delay, I would thank everyone for patiently listening. And I'm honestly touched with experiences and also the presentations done so far. And thank you, Fahim and Mehran.
Thank you so much, Dr. Mehdi. That was really interesting and captivating. And thank you to everyone. If I can just ask all the speakers to actually put their video on. We've had questions. Please continue to ask questions. We'll try and get through as many as we can. There was one regarding the name of the app that you mentioned. Aaliya, could you just tell the audience a little bit more about the app?
Yeah, if I could just share my screen for 1 second. I just want to quickly show. So the app that I use, so firstly, in general practice, the services have to be commissioned by your local CCG. So the app that I have access to is called it's called Consultant Connect. So initially this was set up for dermatology cases. So it's a secure NHS system. So I used to send photos of dermatology cases and get a result within, say, 20 minutes. But now it's expanded to cover lots of other specialities, which I've mentioned on the right, including a COVID advice line. So yes, it's called Consultant Connect. Thank you.
Thank you. There's another question about the NHS long COVID clinics and whether they're currently open. Aaliya, do you have any information about long COVID clinics and their availability?
So I'm just going to go back to my screen share. So in terms of long COVID clinics, I can only really comment on what's happening in my area. So in Birmingham and Solihull, again, we have got communications on an almost daily basis from the CCG, so we can refer. So I'm just showing you this to illustrate that we have a proper referral form on the left. It's several pages long, and the last page is the Newcastle post-COVID syndrome follow-up screening questionnaire. So we are able to do it, but you'll have to check with your local CCG about what's available in your area.
Fantastic. A couple of questions actually, especially from the audience that did the online registration form. So I'm going to start with yourself, Aaliya. How should GPs manage in community when they approach a patient with long COVID, and where are the best places in terms of resources that you would signpost them to?
So I've mentioned some of the resources that were available through like the central kind of NHS England. We've also got locally built guidelines through the CCG, and I think that Dr Seema Charters has shared some excellent resources as well, because ultimately we as doctors give resources, but I think only the patients really know what does and doesn't work.
Yeah, no, very nicely said. There's also another question, Dr Charters, I'm going to come to you for this one. Obviously you had post-discharge pulmonary clinic support. So there was a question around vocal training as well as breathing techniques. What techniques did you find helpful, and how do you approach exercise tolerance post-COVID?
I think the pulmonary rehab team didn't teach me breathing techniques as such, but because I have had knee injury as well, they had to kind of give me something which I can do exercises bearing in mind my knee injury. So they gave me a series of exercise week on week basis. But personally, I feel that the pranayama or the yogic breathing that I did in the earlier stages of the disease, like when I was on the respiratory ward on the 2-3 days before the discharge, I started doing them. It was very shallow breathing I had at that time. I couldn't take a full breath for a number of months, I thought. But I have now come across some videos which people have popularized post-COVID, and I will have a look and post it in the channel. But I wasn't given any breathing techniques as such. I was just given exercises, and I was asked to build on them very slowly, very, very slowly. But you have to keep moving. Even if you feel breathless, you should not stop moving, because you will get deconditioned very quickly after a prolonged illness, and the breathlessness will get worse naturally.
Great, thank you.
Excellent. Next question, Dr. Mehdi. We're going around this virtual room. It's come up, and it's really saying thank you for you, Dr. Charters, a very moving personal story. The question is there a correlation of long COVID occurrence and severity of symptoms with existing comorbidities, level of antibody post-exposure to virus, and level of physical exercise prior to event? So quite a detailed, complicated question, Dr. Mehdi. Please don't hold it against me.
Yeah, let me just read the question, because is there a correlation of long COVID with existing comorbidities and level of antibody post-exposure to virus and level of physical exercise prior to the event? I guess just reading between the lines, I get a feeling how quickly are you going to get back to your normality following a COVID illness. And like I said, I think the comorbidities probably in a younger population are lesser. And that's what I was trying to reiterate, the fact that actually younger people have found it much harder to get back to their normality. I'm not entirely sure whether there is any correlation with the level of exposure as such, because I don't think we've ever checked the level of exposures. But certainly people younger, and I think there's no rocket science in saying that people with comorbidities certainly will take longer to recover. So there is that sense of anxiety and I think apprehension in younger population. I hope I've answered to some extent.
Can I just add to that answer?
Absolutely, please.
The C19 study app did publish on long COVID, and they said the number of symptoms that you have in first 1 or 2 weeks of illness, the more symptoms, the more chances of long COVID. Then if you have got respiratory conditions and if you have got diabetes, then again, they are seeing preponderance of long COVID in these people. So symptom cluster, they have kind of honed on symptom clusters in terms of predicting long COVID.
Fantastic. Thank you, Dr. Charters. Dr. Goyal, I'm going to come to you then. There's one of the questions around the app itself. Is it for GPs or is it for the broader public? I guess you're the app individual for tonight.
Well, so I mean, I've just answered that in the chat, actually.
Okay.
So the thing is, so this is commissioned by my local CCG and it is for GPs. But the reason for mentioning it today was because that prior to the pandemic, there was a very kind of old school way of doing things, which was sending referral letters and things like, you know, waiting for time to get advice back from our specialists, such as Dr. Mehdi. So this app has actually sped up the process. So with skin complaints, as I said, I get results. I get a response within 20 minutes sometimes. So it's just to reassure the patients that there is fast access to consultants for us to help get the information they need, even if patients can't access it directly themselves.
Great, thank you. And someone has had some difficulty with referring one of their patients to a long COVID clinic. I think it was the fact that it got rejected. So is it fair to say it's around respiratory conditioning? That's where the primary focus is, because there's lots of complications in terms of psychiatric, neurological difficulties. So I'm going to approach Dr. Charters for this one. How can they be supported? Sorry, you're on mute.
Psychologically, it's very important to have a family around you. And in this lockdown period, that has been difficult. I was lucky because actually I've got two grown-up boys and they stay away from home. They're working in their own areas and they were near London. But they came home once I got ill. My one son was before with me when I got ill, and the second son also with his fiance returned home. So it really helped my recovery to have family around me, and my friends helped me. My colleagues from work, so many of them were keeping in touch with me. And if you surround yourself with positive people, it does help, because this illness does get you down. You feel down and dumb so many days when you feel that, oh, when am I energy going to come back? So psychologically, your home and your friends are important. And I heard this term on the Cresta Clinic, fatigue management. They call it be aware of energy vampires or energy sucking vampires. So you don't want to be surrounded by somebody who's going to suck your energy out of you. This is really a limited sort of chronic illness. I mean, I'm hoping it is limited and it's not going to go months on end. So all those implications of chronic illness apply to long COVID. And then, of course, long COVID clinics will have counseling support and one can avail those facilities.
Great, thank you, Dr. Charters. Just one last question. I'm going to ask yourself, Dr. Mehdi. Delirium itself, there's obviously evidence that it's related to dementia. Have you noticed from your own clinical practice, because there's some emerging evidence that it doesn't just emerge in older people, but also younger individuals?
To be honest with you, Mehran, personally, I've not seen it, but I'm sure it's certainly something that should be recognizable. I think I'm sure my colleagues may be able to add. I don't want to give wrong information, so.
Over to yourself, Dr. Goyal or Dr. Charters.
So obviously, as I say, I've got access to fast advice through Consultant Connect. So if I have a patient who's presenting with me, I would do what I normally do in the case of delirium. So depending on the individual symptoms, like I, have access to it to admit them, regardless of the long COVID clinics. So the long COVID clinics, they are there, but of course we always have our normal pathways for specialty referral into hospitals.
Thank you.
Excellent. I'm sorry for all of you who are watching. We've just run over a few minutes, and as you can see, Dr. Mehdi is still at work, so I have to let him go home to his family and have dinner. And I think that's the best way to round tonight off. I want to say a big warm thanks to Dr. Aaliya Goyal for spending a lot of time and preparation in getting the slides ready. As you can appreciate, something of this nature doesn't happen overnight. Many hours and weeks have been spent getting tonight ready. The same also for Dr. Charters, but also for sharing valuable insights. We've had a lot of comments as well by people watching saying that you've really inspired them and it's really courageous for you to open up, and it's really hard and it's a really precious thing to share with the audience. So thank you, Dr. Charters, and we wish you a speedy recovery. And
thank you very much.
And continued good health. And also Dr. Mehdi as well. It was really good to finish off the evening talking about your respiratory experience. For many people, COVID is the respiratory experience, and the actual respiratory complications is really a pivotal and important part. So I think you were pivotal to tonight. I hope everyone watching gained something. It was a positive experience. And I hope that we can catch up at a future event sometime soon. As always, please stay safe and look after each other. Thank you so much. I've been Dr. Shakur, and along with Dr. Javed, we've been your hosts for tonight. Thank you so much, everyone, and good evening.
Thank you.